Dr. Mona Tilak ma'am to introduce us to Dr. Bhushan sir.
Good afternoon, everyone. It's my proud privilege to introduce our esteemed guest lecturer, Dr. Bhushan Zade. He is the Director, Department of Radiation Oncology at Ruby Hall Clinic, Pune. He has completed his MBBS from Government Medical College, Nagpur. He pursued higher studies in radiation oncology and clinical oncology from Tata Memorial Hospital, Mumbai. During his residency, he received extensive training in high precision radiotherapy like IMRT, IGRT, stereotactic radiotherapy for brain tumor, and stereotactive ablative body radiotherapy for lung and liver tumors. He was awarded University Topper in MD examination in the year 2019 from MUHS Nashik. He completed DNB in radiation oncology from National Board, Delhi. He joined Ruby Hall Clinic in 2010 as a consultant radiation oncologist. He pioneered 4D CT-based stereotactic ablative radiotherapy for lung and liver tumors in Ruby Hall Clinic. He also started perineal interstitial brachytherapy treatment for difficult female genital tract cancers. Both these technically challenging modalities have yielded very impressive results so far. He has keen interest in treatment of breast cancers, especially in extreme hypofractionation and cardiac sparing radiotherapy using deep inspiratory breath hold technique. He has been a part of bone marrow transplant unit and total body irradiation for myeloablative conditioning. He is the chief consultant and director for the CyberKnife radiosurgery program and treated more than 250 patients in a short span of 1 year. He has been principal investigator and co-investigator for various study protocols. He has delivered and chaired scientific sessions at various national and international conferences. So we are very privileged to have such an esteemed person to give us a guest lecture. So I welcome you, sir, and hand over the mic to you.
Is it okay now? Yeah, good. So we heard about AIs, we heard about robotics, and now I'm talking about radiation oncology, which is one dimension of oncology treatment. We know about surgical oncology, we know about medical oncology, and this is what we are going to talk about, radiation oncology. So what exactly we do and how I'm going to talk about this topic. So I'll just introduce what radiation oncology is. I'll just talk about the workflow of treatment of radiation oncology without robotics, without AIs, and what AIs and robotics have made a difference in the management of cancer in radiation oncology in particular. So radiation, very common word we hear or we know in our basic physics in our high school days. What is radiation? It's emission or propagation of energy through a material medium or space via electromagnetic waves. And radiation has got a lot of kind of a spectrum, starting from very low energy radio waves, or say microwave, infrared, mobile waves, or what Wi-Fi we use at home. Those are all low energy radiation. And what we generally use in a medical field, those are high energy or ionizing radiation. Even in high energy, we have a ortho voltage or a kilo voltage, which generally are used in a diagnostic setup like X-ray or CT scan. And then we have a mega voltage radiation, what we use in our therapeutic radiology or radiotherapy or radiation oncology practice. So how exactly this radiation work when we treat tumor or when we treat cancer? So this destroy radiation, high energy radiation destroy genetic material in the tumor cell. Now what precisely genetic material we are talking about? We are talking about DNA. And this DNA, because of the damage incurred by radiation, cannot replicate, cannot multiply. And when it tries and attempts mitosis, it dies. So the radiation induced damage or radiation induced cancer treatment, the death of cell happens when it tries and attempt mitosis, what you call mitotic cell death. But when this is happening, the utmost importance is to spare normal structure around the tumor cells, because tumor cells are not in isolation. They are sitting there surrounded by normal tissues. And a typical radiation oncology setup, of course, this is just a cartoon. There are specialized machines and departments, but this is a machine which emits radiation. So what we call in a modern world linear accelerator. It uses electron accelerated on a target where the radiation is generated and then directed towards a patient. This is a typical patient and a radiotherapy technologist making patient comfortable and positioning for the treatment. Now, we must have heard like a very common scenario of head and neck cancer, say in India. See a tongue, surgery is done, now patient goes for radiation. Or see a oropharynx where surgery is not possible, patient goes directly for radiation. And the radiation is for 6 or 7 weeks. So what kind of a radiation is that? That we call a conventionally fractionated radiation. So what happens? A big volume of radiation and small doses of radiation continues for 5 days a week for 6 to 7 weeks. This is called conventionally fractionated radiation. So the typical radiation therapy goes for 1.5 months. But then a lot of research has been done to maintain same efficacy of radiation and reduce the duration of radiation to a meaningfully less, to avoid kind of a compliance, to make compliance better, to avoid kind of a healthcare load. And this we call moderate hypofractionation. And in head and neck cancer, in breast cancer, in prostate cancer, that was a big success. We could reduce the duration of treatment up to half. And then for certain sites, like brain tumors, like prostate cancers, like liver cancers, something known as extreme hypofractionation, where number of radiation or sessions of radiation are very small, up to 5. It can be 3, it can be even 1. The logic is we give very high, intense dose of radiation and achieve that. But when we do something of this sort, the normal tissues around that tumor are at high stakes. And we need to have a very specialized department, very specialized team, machines to handle these kind of extreme hypofractionated or ultra hypofractionated regimens to achieve high cure rates without much of a toxicities. And there robotics, AI is going to play a vital role that we are going to discuss in coming slides. So typical radiation therapy workflow, we must understand. See, radiation therapy needs machine, patient has to lie down comfortably in particular position every day. So the first step is we need to make patient comfortable and immobilize. Why? Because if the patient is moving, how would I give radiation to a particular part of body? So patient has to be immobilized, and the immobilization position has to be comfortable, because if the position is not comfortable, patient will tend to move and the entire purpose of high precision radiation therapy would be defeated. So the first step is immobilization. We use various devices depending on what area of or what volume of our body we are treating. Like head and neck, we have a mask. Like for breast, we have a breast board or sloping devices. We have a vacuum bags to make entire body comfortable in that particular position. And then we do image acquisition. So in radiation oncology, what we treat, we see and we treat. So if we don't see, we cannot treat. So image acquisition with a high quality scanner in a different, what we say, stages of respiratory cycle. What happens? The tumors are moving. Tumors are not static. So as we breathe, as the body organs are kind of there is a peristalsis, there is a differential bladder filling, rectal filling. So the tumor is also moving. So we have to acquire the image in a various stages of tumor movement so that we get a full picture of tumor volume in the entire kind of in its range of motion. So once the image acquisition done, the next critical part is radiation therapy planning. Now planning involves 2 steps. First is step done by a radiation oncologist. So system, a computer doesn't know what is the tumor. Computer does not know which volume has got the highest concentration of tumor cells as compared to other volume. Computer does not know which area is at risk when we treat the tumor. So all these things has to be told to a computer, what we call contouring or segmentation. So we draw a volume of tumor, then we draw volume of tumor kind of which is less concentration, what we call high risk volume, low risk volume, intermediate risk volume, and then we draw organ at risk. And then our physics team would do a nice planning to give tumoricidal doses to the tumor volume and spare normal tissues around. Then comes patient positioning for the treatment. Now everything is looking beautifully on a computer screen. But what happens when we take that particular patient for actual treatment? Now, during treatment, patient is breathing. During treatment, patient is anxious. So we have to counsel, we have to make patient comfortable, fine. But what about breathing? It's happening and tumor is moving. So we have to do image guidance. We have to image that patient when the patient is lying down on a couch. We have to match that image with the reference image, correct all those possible errors, and they treat what we call image guidance. But even if we do that matching and we start a treatment, even during treatment, movements are happening. Now, what to do and how to take care of those movements, how to track, that we will discuss in subsequent slides when we talk about robotics and AI. And then the treatment part. So I made a kind of a workflow clear to you. Now let us talk about little history of this radiation oncology. This is a very typical, say 5-6 decade old radiotherapy delivery system, what we call telecobalt. So cobalt source or telecesium or cesium source housed inside this lead kind of a container, and the radiation is getting continuously delivered. Very simple, very robust, but very primitive, was very popular those days. Now we don't use all those things anymore. And the radiation shapes used to be squarish or rectangular. But we know tumors are not square and rectangular. So to make those unnecessary radiation going here and there, we used to use those lead blocks to shield radiation going to the surrounding areas. Then this lead block became more customized kind of a cerebral blocks or lung blocks, but again very crude, very labor-intensive, cumbersome way of shaping radiation beams, and we can use this for 1, 2, or 3 beams. But what if I am using 10 beams of radiation, 20 beams of radiation? These kind of a manual blocks are just not possible. We need something automated, something computerized. Then in early 2000, we got this 3D CRT, multi-leaf collimator, automated collimation devices, which used to give shape to the beam of radiation. And now it has evolved to an extent that any shape is possible with a just click of button. So a typical old plan of radiation, where radiation volume used to be squarish or rectangular, and nowadays we can actually give shape inside the human body as per the tumor size and sparing the normal tissues which are there in the vicinity of the tumor. And these are the all automated devices, fluence mapping, every voxel is fired with different intensity of radiation so that we achieve what we want inside the human body as per the tumor biology. And now what is happening, like everything, all electronic devices which can record either in the form of picture, videos, or text, we are creating a data which are enormous, huge, and the data is coming from clinical encounters, laboratory values, genetic testing, pathology reports, and previous treatment details, and the data is so enormous, what we call big data, and this data is giving us opportunity to mine and get some insight into the disease so that we can help the next patient, next future generation of doctors to resolve some unresolved issues. Now the data is so voluminous, they are sometimes structured, sometimes semi-structured, and sometimes really haphazard. But yes, with the proper mining, we can create some atlases, we can create some protocols that we are going to discuss. And we have different data sources and types, from the clinical data, imaging data, especially in radiation oncology, we have a dosimetry data. Like the same patient, if I am treating 10 head and neck patients, say last month, all 10 head and neck patients are CA oropharynx, and I am seeing some unusual reaction. If I am treating only 10 patients, and all those 10 patients are getting followed up by me, I can appreciate that change. But if those 10 patients are seen by 10 different people at 10 different point of time, those one patient is seen by one particular doctor may not see the patient prospectively and may not be able to identify that change. But if that change is getting recorded and that recorded data is getting into some algorithm, in spite of the variations done by doctors, still the data can be mined and we can arrive to a conclusion that something is not correct or something is missing in that link, and we can correct it. So the dosimetry data, the follow-up data, this data, if mined properly, gives us opportunity to improve. And particularly in radiation oncology, like when I treat a patient with radiation, and I see two parameters. First is oncologic outcome, and second, at what toxicity I am getting that oncologic outcome apart from so many other parameters. Now, if if there is a change, like I am treating a head and neck patient for 6 weeks, and during this 6 weeks there is a weight loss. So whatever planning I have done and implemented on day 1 may not be appropriate at week 3 because of the weight loss. Or if there is a seroma collection, the volume has changed. So, but who will identify this and who will correct for this? If I see the patient, which I have done on day 1, and the same patient is seen by me at day 15, I may be able to identify. But if 2 different doctors see this, they may miss this. So how to correct this? So with this kind of a data in radiation oncology, we can correct this. And again, in future slides, we'll see that. Personalized treatment plans, decision making, these are all general AI-based advantages in general medicine. So application in radiation oncology, I just spoke about adaptive planning. So the volumes are changing. We can adapt our plan in real time with the changing volumes of the tumor, changing volumes of the patient because of some physiological changes happening. We can reduce toxicities with the help of these things. Now the typical algorithm, I will not go into detail of this algorithm, but I'll take an example to show how this algorithm helps. Now, why newer technique? Why robotics? Why AI? Suppose the entire treatment paradigm revolves around this particular graph. In any modern medicine, we have tumor control on one end, we have a complication at other end. We want tumor control early with relatively lesser doses, and we want complications relatively far off. And this is the therapeutic window. And the entire idea of technology, entire idea of AI, entire idea of robotics is to widen this curve so that we can achieve a good tumor control probability at lowest level of complication. Now see this image. I'm treating a patient with CA oropharynx. With the older treatment techniques, I am firing the entire block, giving kind of a rectangular dose distribution. Yes, I am achieving a good tumor control with good doses of radiation going to the CA oropharyngeal area, but I am firing the spinal cord with the same dose. I am firing bilateral parotids with the same dose. Achieving good tumor control, but at higher toxicity. Now I come to a 3D CRT area, 3-dimensional conformal radiotherapy era, where I can spare spinal cord to some extent, but I cannot spare bilateral parotids as I want in today's world. And see the intensity modulated radiation therapy. I can spare bilateral parotid to a good extent with the spinal cord, still giving good doses of radiation to the organ at the tumor area. So I am widening these curves. Now offline. So if I don't have AI, if I don't have very robust algorithms which can make things faster, how would I do? This is a tumor, see a hypopharynx with a bulky neck node. On day 1, I started radiation. Say after 3 weeks, node started responding, and my volume is now touching the skin. Now if I continue with the same plan of radiation for next couple of weeks, yes, I will achieve good tumor control, but I'll end up giving lot of toxicity to the skin because now skin has gone inside the high dose of radiation. Very simple to understand, right? So what I will do, I will just stop, withhold radiation for 1 or 2 days here. I will rescan the patient, I will replan the patient, and I will restart the treatment so that I achieve the same tumor control with good doses of radiation and reduce on skin toxicities, which is happening because of the reduction or response of the node. But it is happening at the cost of 1 or 2 days of miss of radiation and lot of human efforts in the background. But is it possible to make this happen in just couple of minutes? Yes. Now we are in the era of online adaptive radiotherapy. I just spoke about offline adaptive. So what is happening in online adaptive? There is a daily 3D MRI or 3D CT scan happening on table. So our machines of radiation oncology delivery has got inbuilt CT scanner, which takes a CT scan of patient every day before treatment, and that scan is matched with the reference scan, and if the error or if the difference is significant, it does auto correction there, it does auto planning there, it does quality assurance there, when the patient is still lying down on a couch without even patient understanding what is happening in behind, in 5 to 10 minutes time, the new plan is generated and the treatment is delivered. So this is the power of AI. This is the power of high GPU-based optimization, what we are talking about. We need a very high and robust computers, GPU-based computers to handle this kind of a thing. So now let's a few word about radiosurgery. So what we spoke about till now, what was radiotherapy? In radiosurgery, it is not a conventional surgery. We are using intense dose of radiation to a precisely localized volume of tumor or tissue to create effect as if we are doing surgery. That's why it is called radiosurgery. It is very commonly used for brain tumors, early lung tumors, liver tumors, prostate cancer. We are using it very often. But when we use a very high dose of radiation, we have to be very careful that we are not missing the tumor and firing the normal tissues. And this is a typical CyberKnife robotic radiosurgery system. So this is a platform. This is like first in Western India what we have in Ruby Hall Clinic. So this is a fully robotic system. This is a linear accelerator. You can see this X-band linear accelerator mounted on a 3-arm KUKA robo, and it has got a real-time tracking of the tumor, real-time tracking of the human body movements, and those information received from the tracking is given to the robo, and it can correct its position in real time without any disturbance, without any human intervention, and treat with sub-millimeter accuracy. So how the system work? Like if imagine this is a human body and this is a tumor. Now this tumor is continuously moving, say 1 centimeter, 2 centimeter, depending on what volume we are targeting, but this is moving. And irrespective of the tumor movement, even human body externally is moving because of rise and fall of abdomen or rise and fall of chest because of the respiration. So we have optical camera. This is the optical camera looking at the patient's outer contour, and we have a X-ray detector here looking at the internal movement of the patient. Now this external movement and internal movement creates a correlation model, and this correlation model gives information to this treating robo to adapt as per the real-time movement of the tumor, so that we do not miss anything because of the tumor movement. Now predictive AI algorithm. So specially we use this predictive AI algorithm for lung tumor and liver tumor. Lung tumor and liver tumor are the tumors which move most during respiration, as sometimes it can be up to 5 centimeter in various dimensions. And we need a very high dose of radiation to be delivered here, and we have cardiac structures, we have vessels, we have healthy lung around, and spinal cord sometimes. We have to be very careful we don't injure those organs. Overall, this poses a very challenging situation. So how we deal with this situation? So I just showed you a diagram. Now this is an actual picture. This is the optical camera which is watching patient's rise and fall of the chest during respiration. We have this orthogonal X-rays looking at the tumor movement in real time, and then we have correlation map. Now this two information put together creates a correlation map of tumor movement in 3 or 6 dimension, and now this information is passed on to the robo, which is precisely targeting the tumor while it is moving without any human intervention. With this, we end up giving high doses of radiation only to the tumor with sub-millimeter accuracy, no damage to surrounding structure, side effect free treatment, and that too on OPD basis. Patient walks in, takes 15 minutes of radiation, walks out of the department with a cup of coffee, no anesthesia, no pre-medication, walk in, walk out. Now let us see some real life cases. This is all cartoons, videos, industry gave us this with a very sophisticated modules, but how it looks in the real world. So this is a patient, 80-year-old lady with, she is known case of say anal canal, treated by me some 4-5 years back. Now she presented with 2 lung metastatic tumors. Now she is 80-year-old lady, surgery is tough, so we took a call to treat these 2 metastatic lung tumors with this cyberknife technique with real-time motion management tool. So this is how it looks. Can you appreciate? The cyberknife system is tracking the tumor movement in real time, and you can appreciate this graph. This is inspiration, this is expiration, inspiration, expiration given by that optical camera, and this the picture real time given by the X-ray which is happening during the treatment. So the correlation model is created, and the correlation model gives information to the robo, and it treats and see the response. This is a pre-treatment tumor, this is post-treatment no tumor. This is pre-treatment scan with 2 tumors, post-treatment scan with no tumor. And the beauty is not only the tumor is gone completely, the beauty is there is no pneumonitic patch around, there is no area of fibrosis around. Radiation itself is an injury, and any injury will create some inflammation. So we give radiation, we expect some pneumonitic patch, or in later time we expect some fibrotic areas, which is a very common situation, and we are not shy of accepting that. But with this kind of a technology, you don't get any inflammation around, and that's the beauty. So we are curing without side effect. One more very interesting case, CA oral cavity, and on routine follow-up without any, he was asymptomatic, and we got to know that the patient has got a lung metastasis, but it was very close to heart. Actually, it was touching pericardium. You can appreciate here. Now, if I ask my robo to track, I'm little worried that the robo will track the exactly same shadow, because it was kind of overlapped by the big cardiac shadow. So I was not very confident. So what I did an extra check whether system is tracking correct shadow or not by putting a gold fiducial marker inside the tumor. I asked my interventional radiology colleague to put a gold fiducial marker inside the tumor, so that when the cyberknife system is tracking the tumor shadow, I am sure that the system is tracking the correct tumor shadow. So it is like something to be doubly sure about. And then this is a typical cyberknife plan of radiation dose. Heart is well spared, looks good on screen, but how it looks actually on the system. See, my system is tracking the tumor shadow. If I remove the box, I am sure we won't be able to appreciate that shadow, because it is getting superimposed by a cardiac shadow. But the strong radiomics algorithms, AI algorithms, are doing a great job by only tracking the tumor shadow. And now you can see, you can appreciate the fiducial which is inside that box, telling me that system is tracking the correct shadow, because heart is at stake. Please understand why I did this. Then this is the treatment. This is a pre-treatment scan showing the tumor with high uptake. This is a post-treatment scan. No tumor, no uptake. What you only see the artifact because of the fiducial marker which I have put to be extra cautious. And see, there is no pneumonitis, no fibrosis around. So this is the real beauty of today's AI-based robotic system. We are achieving cure without side effects. Again, very interesting case. This is my last case and slide. CA cervix case treated by me in 2014. Since 2021, she has been developing some oligometastasis. Oligometastasis means it is a disease coming back, but with a lower magnitude, 1 or 2 or 3 mets at any point of time. So we don't give chemotherapy. That's overkill, because disease volume is very small, and we keep on radiating those 1 or 2 or 3 areas. So this is probably, it was my 5th or 6th time I was radiating her last to last year. So this time she presented with a small liver disease. I had treated her liver 2 or 3 times earlier, so this was not a big deal. But the important, critical, or a kind of a big deal situation was the pericardial nodule. Now, this pericardial nodule was certainly a disease because of the intense uptake, and it was so small that even my system would not track this, because the liver dome and big cardiac shadow here. So, and I cannot put a fiducial marker inside this tiny pericardial nodule. It is impossible. Now, how to treat this? The cybernet system, every system has got limitation. Nothing is 100%, nothing is foolproof. So what we did, we gave a lot of thought on the treatment of this particular nodule, and then we suddenly realized that this nodule is very close to liver dome. It's very close. So can we fool our system and ask our system to track the liver dome, and with respect to that tracking, we treat this nodule? Is it possible? Not done in, not mentioned in literature, not done by anyone, but we took the opportunity. Patient was our old patient, very close to us. So we took this opportunity and did something very challenging. So can you appreciate, this is a liver dome being tracked by the CyberKnife system. So we fooled the system and asked that system to track the liver dome. And if you appreciate this video, you can see this is liver dome and this is the pericardial nodule here. See, very close to liver dome. So and it is moving also with the movement of liver dome. So we did this exercise. We planned, this is a typical CyberKnife dose distribution plan, and see the response. This is a pre-treatment scan, and this is post-treatment scan. Such a difficult site, but we could achieve cure without any problem to the patient. And this is the second liver tumor, which is a fiducial-based tracking, and we cured that also. And 23, now it is 25, she is still controlled with all this disease. So very interesting, very innovative things we are able to do with the help of this technology, with our experience, whatever you call it, but it's interesting. So robotics and AI in radiation oncology, we are curing with safety. We are making treatment very personalized based on what clinical picture we see, less time consuming because of robust algorithm, and the most important, unlimited possibilities. What we used to think 10 years, 5 years, 2 years back, that this is just not possible. Like this pericardial nodule, a couple of years back, I wouldn't have even imagined treating this kind of a location, but now I'm treating. So this unlimited possibilities with these things coming in, and I thank you so much for my department, for my team, for all the help they are doing, and thank you.
Thank you very much, sir, for enlightening all of us on this crucial topic. What is exactly radiation oncology, how it works, and its pros and cons. Thank you, sir. Any question?
Please
from
feel
audience?
free.
Thank you, sir. It was an amazing lecture, and you made
you.
such a difficult and to understand topic so interesting, and in a very simplified way you have shown us everything. So it was very, very good, amazing.
Thank you so much.